Good morning, good afternoon, and good evening, wherever you are. I am Paola Berberino, and I'm the Chief Executive Officer of Alzheimer's Disease International, and it is my great pleasure to host yet another of our webinars. I know there is a lot of you waiting in the waiting room to join in. So I will be doing a few housekeeping messages before we start with the webinar proper. My colleague Jane is going to tell you how to switch on the automated subtitling. And yes, this webinar will be available on YouTube in a couple of days after we have broadcasted it. I am delighted to have with me some wonderful people that join us from different walks of life to tell us about innovation in diagnostics. Now, Megan, if I could ask you to put in the first slide. So just to check that you are in the right webinar. Yes, that's me. I think I've already introduced myself. Next one, please. I would like to thank, oh, there we go. This is sorry, I'm having a bit of a problem with the slides. Can we put the one that has the title of the webinar, please? So just to check that you are in the right webinar, today we are going to speak about the diagnostic revolution. This webinar is a follow-up of our end-of-year forecast that we broadcasted in December. Next slide, please. And next slide, please. Yes, I'd like to thank the sponsors of this double joint event, Eisai, Roche, and GE Healthcare, that have accompanied us through this series of webinars on the latest advances in diagnostics. Next slide, please. I would also like to thank the many of you that responded to our Christmas appeal. We are a charity and you can always donate to ADI. We are a completely non-for-profit organization, so every donation is put towards some of our purposes. And many of you responded, so thank you very much. These slides also tell you some of our corporate partner and sponsors this year. Next slide, please. As I was saying, you can always donate. Here is a QR code, so our appeal is always open. And if you would like to donate, you're very welcome. In the meantime, you're very welcome to introduce yourself in the chat. And later on in the webinar, please post your questions in the Q&A box. I'm going to say that a few times during the webinar, so sorry for the repetitions. So chat to tell us where you're from, and Q&A if you have specific questions you would like our panelists to answer. Next slide, please. Now, as usual, and whilst you're all joining us, I'm going to ask you to tell us who you are. So we are going to run a very small poll that is going to give our panelists a sense of the distribution of our audience today. So if I can ask Megan and Jane, who are with me on the webinar and are running the webinar today, to run the poll. As you can see, you can choose between a number of definitions. And it would be lovely if in the next couple of minutes, whilst people continue to join the webinar, you could let us know where are you from. And in a few minutes, Megan will close the poll. In a few minutes, in a few seconds, Megan will close the poll, and that will give us a sense of where you're from. In the meantime, thank you so much for introducing yourself. We have people joining us from a reputed 118 countries today, and we have well over 1,000 people registered to attend. Can we know the results of the poll? Thank you. So quite a lot of medical professionals, quite a few carers, some people living with dementia, Alzheimer Association, and researchers. And industry, I would say, are the biggest audience today. Thank you so much. We can close the poll now. And next slide, please. ADI was established in 84. We are an umbrella organization of 105 Alzheimer and Dementia Association around the world. We represent our members at the WHO, at the United Nations, the OECD, and other global and national and regional bodies. We are the promoter of World Alzheimer's Month and the publisher of the World Alzheimer Report, amongst many other publications. We believe in care and inclusion today, whilst we are waiting, hopefully, for a cure tomorrow. And this is also the theme of our webinar today, really innovation in Alzheimer's and dementia. Next slide, please. So in December, we ran our second end of year forecast. The first one was about new therapeutics with Jeff Cummins. The latest one was about diagnostics. And in particular, we were looking at whether we are ready for all the things that the new diagnostic environment is throwing at us. In particular, because we are ADI, we're interested whether governments are also ready to accept the fact that there are better diagnostics out there and that people will demand this diagnosis. And this also has a relevance when combined with the fact that there are new therapeutics out there. At the end of year forecast, I had a fireside chat with Dr. Alireza Atri, and today's webinar will expand on some of the topics and the questions that were raised at that webinar in the area of diagnostic in the Alzheimer and dementia space. Next slide, please. You can access a transcript of the end of year forecast 2025 now, and the QR code on this slide you can point at with your telephone. You can download the transcript now, or you can do it later when we will post this video on YouTube. Next slide, please. And before I leave you for our speakers, let me remind you that our global conference, which some of you know runs only every 2 years, the next one is going to be 14th to the 16th of April 2026 in Lyon in France. And I invite you, if you haven't done it already, to register and join us for the conference. Thank you. Next slide, please. And now let's pass to the substance of this webinar. With me today are Ashton Harper, a Global Medical Affairs Lead for Neurosciences at Roche Diagnostics, Fiona Carragher, who is the Chief Policy and Research Officer at the Alzheimer's Society in the UK, Kohei Sakata, the CEO of Theoria, which is part of the Eisai Group. Now, sadly, Howard Gordon, who is a dementia advocate and former healthcare worker, cannot be with us today. About an hour ago, Howard had a medical emergency. These things happen, and he had to go and see his doctor. He sends you all his best wishes. We send him our best wishes and hope that he will recover soon. But we won't have Howard with us. Last but not least, we have Bina Ahmed, who is Associate Professor of Electrical Engineering and Telecommunication and the General Chair of Interspec 2026. And she's joining us from Sydney in Australia. She's the one that has the toughest timeline. It's about midnight now in Australia. Kohei is the next one because Kohei is joining us from Tokyo. So to all of you that have made a great effort in being with us today, thank you in particular. It's a bit like being at a wedding and everybody that is coming from far, far away is thanked first. But it is true. If it weren't for you making these sacrifices, we wouldn't be able to bring our audiences such interesting and impactful webinars. So with that, please let me introduce you to Ashton Harper. I think we have a slide for Ashton. Ashton will not have slides, but will tell us about his experiences of the latest environment in diagnostic in dementia and Alzheimer. So Ashton, please, the floor is yours.
Thanks so much, Paola. And hello, everyone, and fantastic to be here with you today. So as Paola said, I'm Ashton Harper. I'm the Global Medical Affairs Indication Lead for Neuroscience at Roche Diagnostics. My work focuses on generating the clinical evidence needed to ensure the safe and effective use of diagnostic tests to aid in the detection and management of a range of neurological diseases with a particular focus on Alzheimer's. I come to this role with 10 years experience in medical affairs in the life sciences industry, before which I worked as a doctor in the NHS. So, what's the purpose of my role? I like to think of the fact that the medical world has two distant shores, one where scientists discover breakthroughs in a lab, and another where patients are waiting for answers. And my role, in collaboration with many internal and external experts, is to help build bridges between these shores. And these bridges are made up of evidence, real world experience, and communication, and they take a long time to build, but it's worth it. And my own family, in common with countless others, has suffered the impact of Alzheimer's and other neurodegenerative conditions. And I feel very honoured to be even a small cog in the machine that will defeat these conditions, I hope, in the not too distant future. So I think we're all acutely aware of the many unmet needs in Alzheimer's today, predominantly delayed diagnosis and underdiagnosis, meaning many people living with Alzheimer's are currently locked out of receiving the care that they need and deserve. Today, we're focusing on implementation, so I want to quickly share my thoughts on three things. So, first of all, the tests that we have with regulatory approval and soon to have approval, different use cases and their prioritization, and then finally, pathway positioning. So, in terms of tests that my company has developed, are PET concordant CSF tests. They've been available since 2018. Our first blood test, p-tau 181, received EU and FDA approval last year. And this test has utility in confidently ruling out amyloid pathology in certain settings. And we expect to have approval of our flagship blood test 217 in the coming months. And current data is showing that this is very good at both ruling in and ruling out amyloid pathology. Okay, so moving on to use cases for diagnostics and Alzheimer's and our thinking on their prioritization. So, first of all, triage blood tests. So, we need quick, minimally invasive, accurate tests to aid clinicians' diagnosis. Second, we need confirmatory blood tests, so tests with equivalent performance to the gold standard amyloid PET and CSF for confirming or ruling out Alzheimer's. And then blood tests to identify pathology in asymptomatic people. So the ultimate objective here is prevention. So if we can identify disease early enough and treat before symptoms arise, it's hoped that this would prevent dementia or significantly delay it. Of course, we don't know if that will work yet, but it is being explored in a number of trials currently. Then tau pathology. So this is to help inform staging, prognosis, progression of disease. We recently achieved a tau PET concordance claim for our CSF test, the first IVD of its kind. Of course, we appreciate that CSF tests are invasive and therefore a blood test for this purpose is highly desirable, and we're working on that. And then additional blood tests, so potentially a blood panel to better elucidate different subgroups of patients with mixed pathologies that might benefit from different approaches to management. So finally, pathway positioning. The first point of contact for patients with cognitive complaints is typically primary care, depending where you are in the world. So this begs the question, do we want to give primary care doctors access to blood tests? Now, this is a simple question, but it has a very complex answer. What do we know? Primary care practitioners currently lack diagnostic confidence in early stage Alzheimer's due to the subtle, non-specific nature of symptoms, combined with subjective pen and paper tools for diagnosis and limited time as well. So this leads to two problems. First, inappropriate referrals to specialists, and this is further exacerbating existing bottlenecks. And the watch and wait approach means patients are left in a diagnostic limbo, contributing to the average 3.5 year wait that many experience. So the question is, would a blood test help GPs here? I think the biggest barrier currently is education. These are new tests, and GPs may not be confident knowing how to interpret and action the results. And so to address this, we really need to generate real world evidence to understand the benefits and challenges to using these tests. And this is exactly what we're doing. And we've initiated studies in a number of different countries to look at this. So moving from primary to specialist care, where are we? Plasma p-tau 217, although not widely adopted, is increasingly being used to aid in diagnosis in specialist care settings and is consistently one of the best performing biomarkers. And mounting evidence is suggesting that this biomarker has comparable accuracy to PET and CSF. And the recent Alzheimer's Association clinical practice guidelines published last year advised that a plasma biomarker with a sensitivity and specificity both above 90% could serve as a substitute for these gold standard tests. Now, to achieve this 90% sense and spec, this biomarker may have a dual cutoff approach, meaning that above a certain level, you can be very confident that amyloid pathology is present, and below another level, you can be confident that it's absent. However, this leaves a gray zone in the middle where we're less confident either way. So this gives us three categories, and it's currently debatable what the best course of action is. If the test is positive and an individual is at an early stage and they're eligible for disease modifying therapy, then their clinician might be confident enough to proceed with treatment. If they fall in the gray zone, then they might opt for PET or CSF testing to help confirm one way or another. And if negative, the specialist might consider exploring other causes that are contributing to their symptoms. Ultimately, what we need is regulatory approval of high performance tests. We're there now, and there are more on the way. And two, we need robust international evidence of their utility in real world practice to understand their performance across diverse populations to ensure that they serve everyone. This will take time, but I'm confident that we will get there. And those are my thoughts at the moment. Thanks, Paula.
Thank you so much, Ashton. That was super interesting. And I'm sure that for the issues that relate to the environment in the UK, and in particular the primary healthcare issues, Fiona will have further thoughts around that. Now, I thought that was fabulous, and there's going to be a lot of questions coming from that. Can I remind our viewers that some speakers have slides, some not? If you don't see slides, it's because we don't have slides. I personally prefer not having slides because this really forces me to focus entirely on what the speaker is saying. And in the case of Ashton, he was saying some really, really strong things that we should all be aware of, especially when we're looking at the difficulty from the government side to scale up the issue of diagnostic primary health care, and then the issues that we're having a bottleneck on specialist referrals. This is not relevant to all countries that will be listening to us, which in many, many cases don't sometimes have even many specialists. But there is a lot of what has been said that can be applied more generally. Can I remind you, please, to put your questions for our panelists in the Q&A, not in the chat, because the chat is for introducing yourself and then I will lose the question. So please, if you have a question, if you even have already written it down, please put it in the Q&A box. Thank you so much. Now, can I ask Megan to move our slides to the next slide, please? And can I introduce Fiona Carragher again, the Chief Policy and Research Officer of the Alzheimer's Society, which is going to follow Ashton's presentation from a very interesting viewpoint of the Alzheimer's Society, which of course is doing their utmost best to make sure that these things are not only available, but there is even more discovery. Fiona, the floor is yours.
Thank you, Paula. Thank you, everybody. And hello from the UK. I'm going to talk from a patient advocacy perspective as the UK's largest dementia charity. And I'm particularly pleased to see so many colleagues from Alzheimer's societies around the globe here today. I think we're all agreed that we're entering a new era for dementia. When we think about prevention, diagnosis, treatment and care, we're seeing real hope across all of those pieces of the jigsaw. But today I want to talk particularly about diagnosis. So can we go to the next slide, please? If I talk about some of the gaps that we're seeing in dementia care, one of the big gaps is around diagnosis. And I'm sure that what we see in the UK is echoed around the globe. We know that there are diagnosis delays and challenges. For example, in England, 1 in 3 people living with dementia remain undiagnosed. But we also know it takes on average 3.5 years for someone to get the signs and symptoms before they actually get an understanding of what's going on. Now, as somebody who's worked in our health system in the NHS for 25 years as a clinical biochemist, I've seen firsthand that breakthroughs in diagnostics can actually catalyse real change in a system. So that's in cancer, in cardiovascular disease, and in many other clinical pathways. So we know that getting a diagnosis using an accurate test is important now, because it can be the way in which people access care, support, treatments that we know, such as donepezil and memantine, for example, and enables the family and individuals to put in place their thoughts for the future, but the care that they need now. But we also know it's absolutely vital for the future. For access to disease-modifying therapies, we'll need that early and accurate diagnosis, but it also unlocks the opportunities to take part in research. We go to the next slide, please. At Alzheimer's Society, we talk a lot about it will take a society to beat dementia. So in April 2023, we knew that we had to do something bold and ambitious around changing the diagnostic pathway within the NHS. And with a hugely generous grant from our People's Postcode Lottery in the UK, we launched the Blood Biomarker Challenge alongside partners from other charities like Alzheimer's Research UK and Gates Ventures, but also with system partners with our National Institute of Health and Care Research. And I think this is one of the key learnings for us, is about how you work with a system to galvanise change. This multi-million pound programme was unashamedly about evaluation and implementation of the blood biomarkers that we know already work. So it's not a discovery programme, it's a programme about seeing what will change the system in real life. We believe this programme, because at the moment we don't have blood tests approved for routine use within the national system, will be able to galvanise change and create a pull from both patients and clinicians into the health system, because we're beginning to see in real life how these blood tests can change the diagnostic pathway. We go to the next slide. So thanks to the generosity of our supporters and donors, we were actually able to fund 2 UK-wide programmes. And I'm going to tell you a little bit about both of these, and I'm happy to answer questions later. But both of these were looking at building the evidence to see how do we adopt blood biomarkers into the health system. The READOUT programme was launched in January 2025 and is led by Professor Vanessa Raymond in a laboratory in Oxford. But actually, these are system programmes. So we've got 33 systems across the UK that will be taking part in this really significant trial. I managed to meet the First Lady in the NHS who had a blood test taken this time last year in Oxford, and it was really quite an emotional and extraordinary moment for me, actually, to see this change happen in real life. There's been a digital add-on to this programme funded by the Davos Alzheimer's Collaborative, and I think that shows that you could start to build something really quite significant by actually putting some bold and brave moves into a system. The second study is funded and led by Professor Jonathan Schott from London, and he's looking at a slightly different focus. So he's actually looking just at Alzheimer's disease and p-tau 217. And what we're seeing for him is that, again, many systems across our health service in the UK are taking part, and we're beginning to see that actually the tests that they're using are showing really good sensitivity and specificity, which, to Ashton's point, is incredibly important to get that buy-in from clinicians and policymakers. So we go to my final slide. Now, I recognise for colleagues across the world that this may not necessarily be possible to do in the way we've done in the UK, with big investment, a kind of a bold and ambitious programme. But there are learnings, I think, from the approach that we're taking within the UK. I think it's really important to partner, to really think about whether you're partnering with the health system that you want to change, with clinicians, with academics, with other charities, with policymakers, so that they can understand that this is a change that is coming, but all of us need to play our part. We need to think about how we advocate for this. So thinking about guidance, how we work with in our case, the national health system, but other kind of key parts of the system so that they are not just seeing this at the end of our programme in 2029, they're seeing the outputs and can believe that change is coming. We also need to think about how we inform the public. And we've certainly had a huge amount of media coverage in the UK on this programme because it feels really tangible and hopeful for our beneficiaries, for people living with dementia now and in the future, that things may change. So for us, the Blood Biomarker Challenge has actually begun to galvanise society because it's begun to really be a hopeful message for the future. And something internal, which is really important again for advocacy organisations, this is about using every single bit of our resources to start to change the narrative and the hope and the system for the future. So thank you, Paula.
Thank you so much, Fiona. Thank you a million. That was so practical. And this is exactly why we run these webinars. We would like everybody to be inspired. I mean, the Alzheimer's Society is doing a massive amount of job, a huge amount of lifting, and in particular, trying to involve all the stakeholders, and in particular, the stakeholders that have the power to do this at a scale, governmental stakeholders. That's the only way that we can really get this to more people more quickly. And for that thing that Fiona was mentioning, this moment of realization that this is available, and actually we should do something about it to happen. I see that a lot of you are putting some really interesting questions in the Q&A. We look forward to discuss them. Now, it is my pleasure to welcome Kohei Sakata, the CEO of Theoria, which is part of the ASI group, which will tackle this issue from a different angle. Kohei will not have slides, so please don't send questions about whether we have slides or not. We are not going to have them, so let's hear what Kohei has to tell us. Kohei, the floor is yours.
All right, I thought I did have a slide, but never. Okay, yeah.
Ah, yes, you do have one. Yeah, sorry, my fault.
All right, so let me talk about the ecosystem approach ASI Group is taking. And as Ashton and Fiona already touched upon, I mean, there's tremendous technology development, but we do need a development of social implementation and ultimately, I mean, society changes for behavior changes. So today, let me talk about this ecosystem approach in Japan. And the ecosystem vision is, of course, linked with the early risk detections outside of clinical care system, and then provide potential patients to timely access to the diagnosis. And this is extremely important in Japan because, I mean, we do still have very, very limited MCI population. Only 5% is visiting doctors, and 95% is kind of behind the scene. I mean, who are missing the proper diagnostic opportunity. But before going to the detail, let me also firstly introduce Theoria Technologies, so I can give you where I'm coming from. Theoria is ASI's wholly owned subsidiary, founded about 2 years ago in Japan as a corporate venture building initiatives. And we are driving dementia platform development in Japan under this ecosystem vision. And what's their ecosystem vision? As written on top, we, I mean, of course, ASI's main business domain is therapeutic solution development. On the other hand, we know that like we do need a collaborative efforts across sectors or even industries for end-to-end dementia pathway development. So ASI call for multi-stakeholder collaborations to develop this dementia ecosystem to support our dementia inclusive society where everybody can live fully and authentically without anxiety of dementia. And let me now particularly talk about the early risk detection and diagnostic opportunity provision. Even before Theoria is established or at the early stage of this ecosystem vision forming, ASI had been uniquely promoting the non-SAMD cognitive battery test for several years in Japan market. Why we are making this effort? I mean, because as mentioned, the many population, 95% of potential MCA MCI populations in Japan are not properly diagnosed. I mean, they are missing chance to be properly diagnosed. I mean, simply because, I mean, they don't know the fact that like MCAI exists or proper diagnostic and also like a therapeutic solution exists. And in order to reach broad population, ASI has been working with all kinds of players in various sectors, such as food and hospitality or residential services, insurance and finance, utility services. And it has been gradually and steadily recognized among general public that like brain health care is important. Of course, some of the like a checkup tool, digital biomarkers, etc., cannot directly indicate precise risk level, and we cannot position it as a diagnostic solutions. It's of course, I mean, strictly regulated. However, this is giving a chance, I mean, to let people beware of brain health. I mean, importance of brain health and also like importance of getting proper check at a clinical system. And the theory basically is visioning to accelerate and scale this activity by developing this dementia platform. From consumer point of view, maybe this is perceived as a marketplace, as you can see here. So we basically match make people, those who have pains or challenges, to the right solutions at the right time. We provide risk reduction programs for those who have like concerns, but brain health check result is negative. Or we provide online consultation services for those who have high risk after checkup. And the uniqueness of theory is we do have like a unique or different organizational capabilities such as data science or digital solution development. This is not our today's focus, but we also even can develop digital biomarkers by ourselves. And hopefully, we basically try to combine the like all stakeholders' efforts. I mean, to really develop such kind of ecosystem in Japan, and then realize this dementia inclusive society where we can live fully and authentically without anxiety of dementia. This is our vision. By really like developing end-to-end pathway from early risk detection, right risk prevention, and then proper nudging to let the people to get the timely access to the diagnostic or therapeutic solution at the clinical systems. So hopefully we could be like a crack in the code of challenging like a huge society challenges of dementia. Thank you very much.
Thank you very much, Kohei, and in particular for being so synthetic in managing to squeeze it all in one slide, but that is the way to look at how the ecosystem work. Now, you mentioned two things that I'd like our viewers to think about. One is, and I should also refer to that, the big issue we're having in our community with MCI, that's mild cognitive impairment. This is a big issue for all of us and is inextricably linked with the points allowed now from discoveries to do with prevention and risk reduction. So we do need to embrace the fact that mild cognitive impairment exists. That is not always leading to Alzheimer or dementia, but it can, and it's like a warning sign. This is becoming a big thing for us also to communicate. A lot of our speakers are saying, you know, people are underdiagnosed. We know because we published it in 2021 in our World Alzheimer report. About 70% of people globally are not diagnosed, 50% in high income countries. In some countries, as Fiona is telling us, is better, 60% are diagnosed. But nevertheless, there is still a massive issue ahead of us. And for MCIs, this issue is even bigger because people don't understand what it is. And we will be tackling this at our global conference in Lyon. There's going to be a specific roundtable where we are going to talk about this issue. So for those of you that are interested, and all of us in Alzheimer's organizations around the world should be interested about how are we going to communicate this with our audiences and how are we going to tackle it to have a healthier future for people and actually an healthier present now. So with that little thoughts and hoping that we'll jog some more questions, which please put in the question element of our webinar. can I introduce you to our last speaker? So next slide, please, Megan. And our obviously Howard is not with us. We will be passing to Howard all of your good wishes, which I did see at the beginning of the webinar. So thank you so much. Our next speaker will be Bina Ahmed. Now, it's very rare for us to have an engineer speaking at one of our webinars, and we are delighted. Things are getting so interesting in Alzheimer and dementia that now we are starting to look at other areas of expertise that are coming into our sector. So, Bina, it's a pleasure to have you. Thank you so much for being with us past midnight in Australia. Please, the floor is yours.
Thank you very much for having me, Paulo, and hello, everyone, wherever you are in the world from Australia. So, yes, as you said, I'm going to bring a very different perspective to what's being discussed. My background is in speech processing, specifically speech and health. And so I'll be talking about how speech can be used as a biomarker of Alzheimer's, and from a very academic perspective too, reflecting my academic background. Next slide, please. Next, yes. So I'm not sure how many people are aware of it, but speech is one of the most complex behaviors that the human brain produces. It is so information rich as its production involves the use of the nervous system, memory, executive function, as well as planning and control of all the organs involved in speech production. When neurodegenerative diseases occur, they begin to affect distributed neural systems. So we observe subtle changes in speech, which can often emerge before formal diagnosis of conditions such as Alzheimer's. Some of these communications changes are not even noticed by families. And when I'm saying changes, I'm not talking about things like memory issues or word finding problems. They include things like pause quantity, duration of pauses, the use of filler words, the quality of speech, changes on articulation. So I've got a figure over here which gives an example of speech from a healthy individual and an individual with dementia. And you can see in the red one that the individual in dementia has increased silence periods, that is, those low amplitude parts of the speech signal. And you can see the transcript shows the increased use of filler words. And so this is a very simple example of the changes you can observe between a healthy individual and an individual with dementia. Now, speech has the advantage of being very easy to collect. It's low cost, non-invasive. It's easy to repeat, so it makes it ideal for longitudinal and accessible monitoring wherever you are. We all have access to smartphones, which make it very easy to collect audio recordings. So how does it work? Next slide, please. Now, from an engineering perspective, speech gives us fine-grained resolution into an individual's cognitive motor lab coordination. In my lab, we're investing measures that can capture both cognitive, linguistic, and motor changes simultaneously. So our focus is not on simply using these features in AI models with high classification accuracy, but ensuring that they're reproducible, explainable, and clinically interpretable so that they can actually be used in monitoring and clinical practice. We are particularly interested in features that are independent of the language spoken and the kind of task, because we want to have biomarkers that can be used in any part of the world, regardless of whether you're speaking English or Japanese or Spanish or Hindi. So the goal is to develop robust biomarkers, that can track subtle changes in cognitive decline, cognitive reserve, and in at-risk individuals. So you were talking about MCI. So speech is a very good way of actually identifying people who are not just at MCI, but at risk of going into dementia. So this sample over here shows a green sample from a healthy individual and a blue sample from a person who is at risk of dementia. and even they're both doing a memory test, and you can see the difference even in individuals who are not even at pre-dementia stage. So you can see that the healthy individual is saying the sequence of words much faster, as opposed to the at-risk individual. And the bottom figure just shows just how frequently the speech signal is crossing the zero axis. So you can see just how fast their signal is changing. Next slide, please. Now, what does this all mean? So speech markers will never replace clinical assessment, but they can transform early detection, as I've highlighted, access and monitoring at scale. So one of the biggest obstacles to my work or the work of people in this area is a lack of diverse speech data sets. Speech is unfortunately an inherently private data form, and there are very little data sets that are shared, data sets that researchers like us can work with. So strict ethics guidelines limit the sharing and development of the large data sets that we really need. Furthermore, another issue is that these data sets are not very diverse. They're often collected from very few countries, speaking a limited set of languages, doing a limited set of speech tasks. So then most of the results that you see are actually conducted on small data sets, which lead to biased and misleading results. So another issue is the lack of reliable ground truth. Clinical annotations are often very broad and not at the detail needed to validate things like longitudinal tracking. So it's not enough to say that this is an individual with dementia or this is a healthy individual. We need a little bit more information to validate some of our measures. Another issue is that the protocols that are often used to collect speech have very limited input from the engineering people. And so this means that sometimes the recordings can have limited use. You might have a nurse or a doctor talking over the patient, or the audio quality is poor, the mic is placed incorrectly, or the kind of words that are being elicited are not helpful in generating markers. And finally, there's very little awareness amongst people that of the value of speech as a biomarker for tracking dementia. So I'm not just talking about people who are living with dementia or people at risk of dementia, but even amongst clinicians, policymakers, and regulators. And so this hinders the amount of data that is made available to us. For example, the simple task of saying the same sentence every day or even once a week can provide valuable longitudinal data that we can work with and develop effective biomarkers to screen for dementia. So it'd be fantastic if this big group of people here who are interested in Alzheimer's could actually think of forming a database or maybe even donating their speech, recording and donating their speech so that researchers like us can actually help the community. Thank you, Paula. I think I've said quite a lot.
Thank you so much. And this is so interesting. And I could see the amount of questions that were coming up. Dunque, first of all, I need to tell everybody that we are going to have a few companies that are doing speech analysis at the conference, presenting what they are doing. Because what Bina is talking about is not science fiction. This is happening now, and people are developing tools. And I think what Bina has thrown us, this gauntlet of creating a speech analysis data set that can be used longitudinally is so critical. In so many countries, I live in the UK, this is still science fiction. So if you go to your primary healthcare doctor and ask for them to record your speech, because at some point in the future, it may be possible to detect whether your cognitive capacity is deteriorating through the speech, they wouldn't know what to do. They wouldn't know what you're talking about. And this is a big challenge for all of us. So this is not something that is going to happen. We need to make it happen. And this is why we are running this webinar. Now, without further ado, there are tons of questions in the Q&A box. Can I ask everybody that has asked the question and put it in the chat, please to transfer it to the Q&A box, because now we have time for once in an ADI webinar to take our time to answer some of your really interesting questions. And the first question I'd like to start with is a question that I saw very early on, which seems to have disappeared. Oh, well, that's interesting. Which was actually on the issue of blood-based biomarker. It's gone. So I'm going to take a other question. This question is from Valerie Bosch. And the question is, how do you view the ethical dilemma of knowing that you are asymptomatic but positive for amyloid plaques? Especially at the moment, there are no curative medication. We are currently discussing this question in several working groups and how to handle it. This is a big question. I would like to open this question with Fiona, because I'm sure that you guys have been debating it. But please, all panelists, can you please come in on this one?
So the way that we've been approaching this is with the blood biomarker challenge. I think, just to be really clear, we are looking at people that are symptomatic. So have symptoms that would already be in the kind of memory assessment pathway. And what we're trying to do with using the biomarkers at that point is to say, can we make it quicker, easier, cheaper, more accessible, and catalyze a complete change in that diagnosis pathway? What Valerie's describing is essentially asymptomatic screening. And we have been thinking about talking about this in the context of prevention and risk reduction. In the UK, like in, I'm sure, many countries, there's a very high bar in terms of, particularly with the do no harm, when we think about a screening program. So going in with asymptomatic testing, we are a long way off that, because what we don't have at the moment is a really strong diagnosis to treatment pathway. So as Valerie said, why would you know? Because at that point, there's, you can't access treatment. So I think it's one of the biggest kind of ethical challenges, but also one of the biggest opportunities that we have as a system, an ecosystem across the globe, to develop the evidence to fill in that gap. So actually that we can be able to be clear that if we do go for asymptomatic screening, we've got a pathway to treatment in place, but also we really understand what that result means for an individual. And I was the director of newborn screening for decades, Paola, before I moved into Alzheimer's and dementia. And it was in rare disease and in childhood disease. And you need a very high bar of evidence to be able to confidently go to asymptomatic screening. And as a community globally, that is one of the challenges and one of the gaps that we need to build together.
Yeah, this is going to be a big challenge. Ashton, I can see you've got your hand up
Yeah.
on this one.
And really important question, and it's difficult. I mean, I guess the situation is that once we have symptoms present, there's already been a significant damage. There's been a significant loss of neurons, brain cells, and the idea around detecting disease in asymptomatic individuals is this ambition for prevention. And I think it's unlikely that we're going to develop a medicine that, once we've got symptoms, can somehow reverse us back to an asymptomatic stage. So I think there is importance in trying to identify very early on, very early stage disease in this asymptomatic population. But clearly, we know that not everyone with these biomarkers, with amyloid and tau, will definitely go on to develop dementia. But I think maybe we'll get to a stage, potentially, this has been said before, of viewing amyloid almost like cholesterol, and thinking, can we find a high level of cholesterol before we've got angina or before we have a heart attack? And I think that's probably where we need to get to. But again, this is, the big element here is going to be medicines, as we talked about, safe and effective medicines that if we do detect that disease early, we can actually make a significant impact.
Thank you very much. I'm going to move to the next question because we have so many. I found the question that had intrigued me. is a question from Neil Chadbourne. Quick screening for Alzheimer's is good, but does it further disadvantage screening and detection of other types of dementia because it may promote blood test only approach? This is an important question. We do not just represent Alzheimer's disease at ADI, we represent dementia globally. That includes Lewy body and vascular dementia and frontotemporal and the 100 plus ways in which you can develop dementia. So can I ask our panelists whether anyone would like to tackle this question? Fiona.
I'm happy to start, Paula, because it is something that we are really thinking about in the UK and Alzheimer's Society. I think two things I would say is that with the work that we're doing on the Blood Biomarker Challenge, this is not a blood test only approach. It is how you use a blood test to enhance clinical decision making. So it's made in the context of the clinical symptoms and the family history and all other kind of like a normal clinical diagnosis is made. So certainly the where we're putting our kind of weight behind is an enhancement to a clinical diagnosis as opposed to a replacement. So that's the first point to make. I think the second point I would make, and I think it's really, really important that Neil's raised this, is that most of the breakthroughs that we're seeing and the hope and the pipeline of drugs, for example, in the clinical trials environment, are for Alzheimer's disease. And I think it's really important for us as a broader dementia community to ensure that we're starting to develop that pipeline behind, whether it's the best and brightest young researchers to start their career in Lewy body or frontotemporal dementia, or whether actually we think more creatively about the clinical trials environment for these non-AD and obviously the diagnostic environment as well. So I think that certainly our approach is that the blood tests are an enhancement, not a replacement to clinical diagnosis. And there's something for us as a community about making sure we have got that pipeline for other dementias as well as just for AD.
Okay, so you're working on it. Ashton.
Yeah, I was just going to say as well that we have a broad pipeline and we're not just focused on Alzheimer's. I just say that we are furthest ahead with Alzheimer's, but we have, ambition to have biomarkers to detect multiple other causes of neurodegenerative conditions. And I think, even where we are at the moment, being able to either rule in or rule out Alzheimer's, that at least gives us information. If we're ruling it out, then we can explore other potential causes. But I think it's an important question.
Thank you. So it's good for everybody to know that we are looking at a lot here, and researchers are looking at things which are beyond Alzheimer all the time. Now, I'd like to pass to some more specific questions. We tackled two big ethical ones. So this one is for Bina. Bina, one of our attendees asking how early in, before MCI, dementia are subtle speech changes detected. So how early it is that you can pick this up? And there is a second follow-up question for you, which is there an ethical debate about the problems associated with using language for Alzheimer's diagnosis? How can the patient consent be made a reliable prerequisite for diagnosis in every case?
So speech has been used as in a lot of clinical tests for a long time. So there's the classic cookie theft test that clinicians do, and so its used to screen and to diagnose is proven. However, the use of biomarkers there's not much clinical studies been done because we're still at the investigation stage, right? So I cannot conclusively say that it's proven to be validated. However, I've been working with as part of my research with colleagues in medicine, and we've been looking at an intervention study. And in that, we were able to classify or discriminate between individuals at risk, who clinicians classified at risk. They had a battery of tests for that, and healthy individuals, with accuracies in the high 80s. But again, these are very small samples. So, 80% can be good. It could be better if we had more data available. So that's the answer to the first question. The second part about the ethics. So the issue is speech is inherently identifiable source of data, just the markers in speech. And so potentially we could have consent like what the tech companies do, right? When we're using Siri or Google, we consent to a lot. We give them our speech on a daily basis, multitudes of times, right? And so potentially that could be something that could be factored in. When nowadays, clinicians do transcription services. A lot of my GP does that as well too. They're transcribing the whole session. But maybe what could be factored in is consent to share that audio recordings with researchers, or there could be a body which manages all that data. So
Thank you very
that's
much.
a discussion to have, I think.
And I think you have a very good point. System to gather consent at scale already exists. It's just an issue of making it happen. Bina, you will also notice that in the questions, there's plenty of people that have sent you their emails because they would like to talk together about creating some kind of repository. So you may want to collect those in due course. Now, Kohei, this one is for you. It's from someone called Pasquale Monteleone, who I guess is a fellow Italian. So it says, thank you for presenting such an interesting hub. Where do you see the biggest opportunities as well as potential challenges to efficiently scale up your platform and generate impact in favor of both patients and healthcare system? Arigato gozaimasu. Excellent. I can speak Japanese as well. So go ahead.
Yeah, thank you for question. And let me start with the challenges and then alongside opportunity I see. So the biggest challenges in Japan, I mean, particularly, or in some other countries, the prevention is not incentivized because of, I mean, too good healthcare system. I mean, most of insurance, healthcare insurance are covered by the government equally. So the general public has more tendencies. I mean, only after having the symptom, they go to see doctors and then get their, I mean, therapeutic solutions. However, I mean, of course, I mean, prevention is better and prevention is important, but it's hard, I mean, to really change the behaviors of consumers. I mean, who get used to go to see doctors only after symptom is appeared. And I mean, as you know, proper intervention is quite important. I mean, at the MCI, mild cognitive impairment stage, for example. So we do really have to consider all kinds of different type of tactics to incentivize the people to get to know that brain health is important, etc. I mean, the opportunity side is, I mean, I cannot really say this opportunity, but the reality is, we do have a social system challenge in terms of increasing medical cost. And I mean, particularly in Japan, I mean, we do face the lack of caregivers in very, very near future. I mean, literally speaking, there are not many caregivers, I mean, who can satisfy the demands of our caregiving. And I mean, as you may know, dementia is one of the biggest reason why we do need more and more caregivers. So the government is also really trying to shift their focuses on a caregiving to a right treatment to prevention. So prevention will be more and more featured. I mean, simply because, I mean, society will not be tolerate with the aging challenges. And there will be more and more debates and public comments on, yeah, prevention is the best way. And that's where, I mean, for example, in the Davos Forum recently, as some of you may know, brain economy was called for. And we do really hope that this kind of agenda set by broad stakeholders will be really penetrated through so that people's behavior will be shifted toward preventive or early risk detection and prevention.
Thank you, Kohei. This is an important debate, and as many of you know, we obviously are part of the UN debate on and aging generally, both from the point of view of aging well, which you've touched upon, but also from the point of view of caring well now. And there is a difficult line that ADI has to walk between the fact that we are entirely in favor of risk reduction and prevention, Although personally, I think that labels that are around brain health are too vague. We must be very careful to keep our community focused on dementia. This is why we advocated and obtained a global dementia action plan, not a vague action plan. It's a very specific action plan. And many governments, especially in low and middle income countries, can hide behind a more generic label because that allow them not to think about the social care issues that we have now. We will be very active in the future years around the aging debate because really, as you say so strongly and so strikingly, there's just not enough carers for an aging society. This was clear from projections that were presented a few years back around the growing aging population, but our societies are changing. And Japan's society is kind of showing the way to all of us. Japan and Italy have been the countries for many years with the lowest growth. And in both societies, the family structure is changing massively. A lot of us have had to rely on family carers, often very little prepared, because as we know, at primary healthcare level, as many people say in the question, why should we diagnose if we don't have a pathway? So this has been an ethical dilemma that has existed in our area for a long time, but not any longer. So now the possibility of diagnosis and of prevention actually starting to become real. So we really do need to open this Pandora box and talk about it more openly. So thank you so much for that. Kohai, there is a lovely follow-up question for you from Gita Dorki. She says, may I ask you if you allow any age group to access the proposed ecosystem? Does it include younger children as well, 7 years onwards?
Yeah, I actually indeed love that question because I mean that's a very important point. I mean, we actually believe that inclusivity, I mean, really like includes the age as well. So, I mean, for example, I mean, when it comes to this kind of advocacy efforts, education is important, and we cannot wait. I mean, for like children to get like aged. I mean, to understand like brain health challenges or like what's good for brain health. So first, we do believe that like our activities, I mean, should extend or include some kind of maybe like a living level type of activities or educative activities. I mean, it's part of advocacy initiatives. I mean, to really consider the early entry point. I mean, could be actually the through the education system, so that like all kind of other healthcare challenges had been properly like well advocated and educated on early kind of stages, and this could potentially trigger. So second point, this could actually trigger the domestic or the household conversation within like a across several generations. And that's super important because, I mean, sometimes it's hard. I mean, I see some other kind of challenges that like elderly generation in general doesn't have a smartphone access or doesn't have like high digital literacy. However, we can consider like a grandson or granddaughters could be a channel to deliver the right messages to those elderly population. So we also do see, I mean, because these young people are kind of being crazy at digital things. So you can imagine that like even this like digital biomarkers, I mean, speech biomarkers, I mean, instead of like directly reaching to elderly population, why don't we leverage those children generation to nudge their like parents or grandparents? I mean, to try it. Why not? I mean, for your like brain health, I mean, this could be considered as a part of ecosystem approach. So I really appreciate the opportunity to have this kind of a comment in this forum.
It's so lovely, isn't it? Things that only 20 years ago we would have thought impossible or science fiction are all very real. They are happening, they are completely possible. I want to change note a little bit and open it up to all panelists. We have a great question from Anders Vimo. If GPs don't have access to blood-based biomarker, the specialists will be even more overloaded with referrals. Correctly use blood-based biomarker as a risk indicator of AD in primary care, a high NPV, lower PPVs in primary care and on specialist level can, together with cognitive testing, etc., serve as a filter for the specialist. So any comment on that?
Yeah, I'm happy to come in. I mean, I think at the moment we don't really know. I think there's some valid concerns about, like I said it when I started speaking on the panel. There's some valid concerns about bringing these biomarkers into primary care at the moment because they are so new, and there's a significant educational there's a steep curve for education really. So the theory or the hope would be that they improve referrals, make referrals more efficient between primary and secondary care if you can actually identify the presence of disease earlier. But I think the concern is that actually it might not decrease these referrals. And we simply don't really know at the moment because they're not being utilized there. So what we need to do is generate evidence to find out if they are effective and GPs can use them and it makes pathway efficiencies. And that's what we're doing at the moment. But at the moment, it's very difficult without that evidence to say what the benefit will be.
Lovely. Thanks, Ashton. Fiona, you want to come into this one
Yeah,
quickly, please, because I've
I
got
think,
another question for you.
all right, so just to add to that, I think what will be really important is to make sure that we're really thinking about it from an inequity perspective so that there's confidence in interpreting the results dependent on what age, what sex, what ethnicity you are. That's really going to be important to give that confidence for use in primary care. But if you follow what other clinical pathways have done, you can start to see that if we build the evidence and we're confident in the use, you could actually use that kind of triaging, kind of give you the kind of rule out bits that actually you're using your very expensive kind of PET CT, MRI for those that actually are much more likely to have disease. So you're kind of streamlining the pathway. And that's what happens in other like cancer, cardiovascular disease. So long way to go, but I think some real potential.
That's such a good point, actually, because again, resources are limited, so we have to think three-dimensionally about how to utilize those better. Now, the other question for you, Fiona, is do you feel the patient voice was heard in the NICE decision for DMT reimbursement, or is there more to be done, and what can be done? This is such a now question, isn't it? Big
It's such
question.
a now question, and I think that for context for colleagues globally, so in the UK, we have a situation where the first two drugs, lecanemab and donanemab, have regulatory approvals, so they're licensed as safe and effective, so you can get access to them. But at the moment, they are not our paying systems. So whether it's free on the NHS at the moment, the decision is that neither meets the clinical and cost effectiveness bar for it to be free on the NHS. At Alzheimer's Society, we think this is a work in progress. We're looking to global colleagues in the US and Japan and otherwhere who are using these drugs. The real world evidence is growing rapidly, as is the science. So we're seeing moving away from infusion technology to subcutaneous and potentially even other forms of giving. So I think it's a work in progress. To the point about whether the patient voice was heard, there was patient voice within the NICE decision-making process. I think that for us, we see that the system is just not ready, whatever the decision is made, and diagnosis is fundamental. This conversation is so important because unless we get an early and accurate diagnostic process, pathway in place, no one's going to get access to the treatments going forward. So the patient voice is fundamental in all of this, Paula, and diagnosis and treatment and prevention and care.
And we can expect a lot more discussions on this when we are in Lyon, because as many of you will know, the French government decided not to reimburse, and that has created huge problems with France. This is in part why we're doing the conference in France. The French government was one of the first to have a plan for dementia, and they've gone backwards, not forwards. So we can never think that our movement has really had advances until those advances are in law, they're legislated, budgeted for, but also we have to continue advocating because if we don't, things will be taken back from us. Now, I have here an interesting statement I'd like to read and ask for the panelists' comments on. This is back onto ethical issues. On one hand, this is from KJ Levan. On one hand, biological transparency respect autonomy. People have a right to know the risk to plan, participate in trials, adjust lifestyle factors, structure finances, or make family decisions with foresight. On the other hand, we are handing someone a risk clock without a definitive timeline and without a cure. There is a similar question later on in Italian, which says, where services for dementia are scarce and not very efficient in giving assistance after dementia, what sense has it to have a diagnosis? So this brings us back to the very beginning. Which one of the panelists would like to tackle this series of things? Anyone with their hand up? Okay, I will tackle this then. I mean, back in 2021, when the environment for diagnosis was not very strong, we published the first of our report on diagnosis. The year after, we published the report on post-diagnostic support because we wanted for people to have very clear in the mind that the two are inextricably linked. And this year we published the World Alzheimer Report on rehabilitation, in particular because we wanted the people to understand that even if there isn't a therapy, if there isn't a cure, there is still a lot that can be done in terms of therapeutic support and rehabilitation. You can still have a slowing down of cognitive decline through non-pharmacological intervention. This is happening. And this is what people still don't understand. You think that you shouldn't give a diagnosis because there's nothing to do. But there is a lot to do, and there is a lot that families can prepare for. And our Alzheimer's Society all over the world are there with that information that often governments don't pick up and then don't distribute. And that is heartbreaking because so many people, so many volunteers are working gratis et amoris Deo to provide this information. Fiona.
Yes, and I think you're absolutely right, Paula. I think two other pieces that I would add to it is that we've got very strong evidence that now in the UK that if you're undiagnosed, you're far more likely to end up in an emergency department. Your carer burden, you're likely to end up in crisis. You're more likely to go into hospital, and you're less likely to get out of hospital quickly. So the system impact of not diagnosing is significant. And then finally, there is a moral piece around this. So we've done a big piece of work looking at 1,000+ people post-diagnosis and asked the question, are you glad you had that diagnosis? And it was overwhelmingly, like over 95% of people said, yes, I am glad I now know I have a name for the symptoms. I can put in place the care. You're quite right, Paula, that post-diagnostic support and treatment isn't there, but people are really pleased and glad that they know it was scary. There was a lot of stigma around it, but it was a positive thing for them to do. So there's a moral piece on this.
Thank you very much, Fiona. I think it's so important in our community, and I know that the two people that raised these questions do belong to our community and are active volunteers in their organization. But we do need to continue to remind ourselves why these things are important and why we need to debate them. And this sometimes is the expression of frustration of people because they are being brought back. There is a question here, which I would like to take last, from Valerie Powell, and she opens up a completely new chapter here. Have the insurance and employment issues been considered? For example, in pilots and heavy equipment operators may not want to be tested early. Now, the whole issue of labor, I was writing today the draft of my speech at our conference, and I still think that is a massive topic that we will need to continue to work on. In our experience at ADI, global labor and trade organization have really not wanted to engage with this issue, and yet it's so important. But Kohei might have some inkling here because, of course, Japan has been looking at the insurance model for a time. Kohei.
Yeah, we do debate this every day. Are we be like trying to screen? I mean, somebody who may miss the employment opportunity by having like a risk check. I mean, and our answer is, I mean, we do need to have like a social care or a social kind of like a system to implement the safety net. I mean, that should come hand in hand. I mean, yes, right? I mean, if we microly focus on like detecting the risk. I mean, this could indicate a certain kind of, challenges. However, that shouldn't, prevent us from helping people to get properly diagnosed because, there are improving technologies and solutions. And as we just debated, if we know risk earlier, there are, ways, to do something. In that case, we do believe that we have to really shift the like a time window of this kind of brain check much earlier. Because if we target like elderly generation or elderly workers, for risk check, of course, we hesitate. I even hesitate. To take it. At that moment. But why don't we start now? I'm on 40s. And if 40s have a proper kind of, understanding of like what are the proper, dementia cares or clinical solutions, we are not so much kind of, scared, to really face the realistic challenges. We can be better prepared. So hopefully we can really make a paradigm shift, through such kind of, changes.
Kohei, thank you so much. This is all we have, I'm afraid, today. There is still 25 questions that we haven't even answered. What is great to see is the amount of interest and engagement in our community about this. So we have, of course, several occasions during the year in which we can engage in this discussion more forward. Our job at ADI is to take some of this science, which is actually not very easy to explain, and try and make it more understandable so that all of us can go back and try and look at how in our healthcare system we can integrate them and explain it to our policymakers who often don't really speak our same language. So I hope we did a little bit today about demystifying the whole issues around diagnostics. I do hope to see a lot of you in Lyon. I thank you very much for following us up until now. I remind you that all the webinar materials will be available on YouTube soon. And with that, I thank you all and hope to see you soon in France in April. Goodbye.